Hello, everyone, and welcome to the webinar. I hope you will like today's topic. And please feel free to use the comment box to share your questions and to comments with us. And uh, like always, this webinar will be also live on many of the Chinese channels so that many of our Chinese colleagues can actually benefit from the lecture as well. And this will be also, broadcast on neurosurgical.tv. So please feel free to share where are you from in the chat box. I will be really happy to see you and say you hello. Hello, everyone. Hello everyone. We will be starting shortly, as you can see. So, we are just 6 minutes left. इसके अंदर भी वो आ रही है तो कुछ भी ना बना Hello, everyone. Thank you very much for joining us today. We will be starting shortly. As you can see, we've got just 4 minutes left to start. And Dr. Jan Dong is also here. Dr. Jan Dong, how are you doing today?
No, hello, hello. I'm fine. Oh,
Good to see you. Good to see you. How is
good
everything
to
at
see
your
you.
end? I've got some issue
Yeah,
with my camera. I'm setting up my camera actually.
yeah. Everything goes well.
So how's your baby boy? We had the pleasure of seeing him last time.
Now he has fever now, and he is sleeping now.
Okay. I think that
Yeah,
it's about 10 p.m. in China right now.
yeah. It's 10:30 p.m. now.
Exactly, 10:30. So it's quite late for him, and I believe that he's a good boy.
Thank you.
Mm. So it was so good to see him and to get to see him and get to talk to him. Looking forward to your workshop as well, coming on 19th this month.
Yeah. I'm ready. Thank you.
Yes, I think everyone is quite excited about about your workshop, and it's going to be very insightful, informative.
Yeah. Thank you.
So let's wait for Professor Atul to join.
Yeah.
So I believe that we've got the different, several of our um, attendees are already here. So let's see if they wish to say anything. Dr. Atul is also here. Hello, sir. Hi, sir.
Hello, Noor. How are you?
I'm doing great, sir. How are you doing today? So good to see you.
Very good. Thank you. I can see my dear friend Yang Dong also. Where is
Salute.
where is the son of Yang Dong? Where is your son? He's not
He's sleeping,
okay.
and he has family staying.
Mm.
Very good, very good,
We've been
very good.
talking about him. We've been talking about him, sir, and we will follow. I've been following your activities around the world, and I believe that you had a wonderful trip and wonderful conferences as well.
Yeah. Too much travel, too much travel.
Ex Exactly, sir. But it's going to be like it's like a Marco Polian excursion for a neurosurgeon, and I believe that it will be so beneficial for everyone who is around you. And I think everyone is so lucky that they can have the chance of learning from you, and so unbelievable.
Thank you, thank you, thank you, thank you, Noor. And your program is becoming very popular, right, Noor? I can see that.
Yes, sir. I believe, sir, because everyone is a huge fan of yours, and I can see that there are so many people who are watching you on YouTube as well, and on neurosurgical.tv, and in China, Dr. Yandong must have that access. There are so many viewers over there, and after the show, sir, everyone going is going to watch the video. There are a large number of viewers that I can see after the show is over. Sir, you are basically a huge legend and so much popular among everyone. So whoever, like, I received so many phone calls still, and they ask that, okay, Professor Dr. Goyal is he's having a series. I said, yes, really, you can be there also. So, sir, thank you very much. We owe a lot to you, and we are really indebted to you for this huge privilege.
Thank you, Noor. Thank you, thank you.
And we are so excited for your lecture today, because everyone is like, okay, you are going to teach something very, very important and very, very serious. So I believe, sir, sir, if you wish, can you can test your screen
Yes,
share?
no. Okay, just let me check. So it is working, no problem.
It's perfect. It's perfect, sir. Like always. Thank you very very much, sir. Sir, would you like me to proceed with the program now?
Yes, let's begin. Let's begin now. Okay.
Thank you very much, sir. Thank you so much, sir. Sir, so again, just a formal welcome. I believe nobody needs an introduction of Professor Atul Goyal, such a big legend. And like I say, I can't even believe myself that we can have this privilege of learning from him. And having this series, running this series was, I believe, one of the most brilliant moments for me for my career. And yeah, while I've also co-chaired several other programs, and especially for the brain tumors, etc. But it's a huge privilege to host this program, sir. So thank you very much for joining us today, and it's a privilege to have Professor Atul Goyal and to feature his third webinar with us, the Pak-China series. This webinar is also being it's live streamed on my YouTube channel on neurosurgical.tv, and also on Chinese channels in Chinese language, so that everyone can actually have this privilege of learning directly from Professor Goel. Sir, thank you very much for joining us today and for sparing time from your busy schedule. I know you've been so busy and it's had been really hectic, but you are an inspiration for some reasons. So many reasons there are, but one of them is your dedication towards education. So thank you very much, sir, for joining us today and for teaching us about surgeries for arteriovenous malformations. So it's going to be a wonderful topic today. Thank you very much for joining us today. The podium is all yours and the time is all yours as well.
Yang Dong, you want to say some nice things?
Yeah, I cannot wait to learn the last chapter of neurosurgery, please.
Okay, let me share the screen. So I will be talking on arteriovenous malformations of the brain. And I have no hesitation to say that this is the last chapter of neurosurgery. This is the most difficult chapter of neurosurgery. In this chapter, you must know your own personal level of technical understanding, technical competence, your ability to work in a bloody field, your ability to enter, and your ability to come out. So you have to know your own skills and your own talent, because it is not like a meningioma surgery where you go and if you cannot remove, you can do partial job. Here you cannot do partial job. You have to either not touch it, or if you are touching it, you have to complete the job and come out. So this is one large AVM. When the AVM comes to you, you have to decide. Yes, there are some good points, there are some bad points, there are some difficult points, there are impossible points. So one is you have to know the AVM. So this is the AVM, yes or no. And there are all kinds of AVM. This is, of course, a dangerous looking AVM. So when I see an AVM, I have to first find out the anatomy of the AVM, the nature of the AVM, and whether surgery is possible by me or not. So everybody has to decide for himself. It is not that this AVM he can do, so I can do, or he can not do, so I cannot do. It is not like that. So in my estimation, there are two types of treatment for AVM. One is no treatment, don't touch it, just leave it. Or you operate and remove it. So you see my circumference for AVM is quite small. Now, whether you can treat by partial embolization, like you do some embolization, at least reduce the size. So that is under evaluation, that has its own controversies and own limitation. Whether you can give gamma knife and do a partial kind of embolization, partial kind of treatment by gamma knife. I'm not an expert on gamma knife, but there are some people who say gamma knife can be a good treatment. Some people say partial or good embolization can be a good treatment. But I will give you my perspective, my understanding. My understanding is a lot of AVM can be removed surgically. And wherever we cannot remove surgically, partial treatment by embolization in some cases may be a good option, like nidal aneurysm embolization or feeding vessel aneurysm embolization, and some partial embolization of weak spots. Weak spots of AVM is possible. And some AVMs which are in any case not suitable for surgery, you can try to give some radiation. So those are the things. Basically, all the people in the interventional radiology field also think that if you can remove the AVM completely by surgery, that is the best treatment. But that understanding and that is left on the surgeon. One, I call it the last chapter because in AVM treatment, AVM surgery, the surgeon has to understand his own self, his own competence. The surgeon has to understand the AVM, and surgeon has to be strong enough, experienced enough, technical wise, technological wise, everything coming in picture that he has to remove. So one little article I had written a long time ago about what is the status for surgery. For several decades, surgery has been performed, and surgery is the most accepted, most recognized, and most understood treatment for AVM. The questions arise, and those questions have to be answered. In our life of neurosurgery, when we travel in the field of neurosurgery, bleeding happens, and we have to handle the bleeding and achieve hemostasis. So art of hemostasis, art of how to achieve hemostasis, whether to coagulate, whether you use gel foam, whether you use Surgicel, whether you use bone wax, whether you use pressure, whatever you use, you have to use it. And for every occasion, you cannot just, it bleeds and you start coagulating, coagulating, coagulating. That is not the way to handle any bleeding. So we have to learn the art of hemostasis in our subject of neurosurgery. And AVM is the ultimate of that art of hemostasis. So what matters in AVM surgery is, what matters in AVM? Now you will ask me what matters and which AVMs are suitable for surgery. So I have to show you several AVMs. Just enjoy the images. So this is an AVM which is located in the frontal brain. So this AVM is relatively in a good area for surgery. This is a relatively large AVM in the frontal base, supplied by the anterior cerebral artery branches. The location is good for surgery. This AVM, parieto-occipital AVM, is another good location for surgery, another common location for surgery. But if you ask me, what about this AVM? You see, in this AVM, there are intranidal aneurysms, large aneurysms. There is a feeding vessel aneurysm. So when you see feeding vessel aneurysm, when you see large blood vessels, feeding the AVM, large blood vessels draining the AVM, it is a high flow AVM. What matters in surgery for AVM is the degree of flow. Higher the degree of flow, more difficult it becomes. Then, of course, the location. Because if it is in the frontal brain, it is a good location. Here, when it is in the posterior parieto-occipital location, it is in the visual cortex, and you have to be careful about those things. So every AVM is difficult, every AVM is dangerous, and every AVM will test your understanding. Now, this is a large AVM in the posterior parietal area. I will say that you see the large blood vessels feeding, and there must be large blood vessels draining. Just a minute, just a minute. So there must be large blood vessels are feeding the AVM in the posterior parietal area. Now I will say one very important thing which I have to tell you is when you are operating on such an AVM in the posterior parietal area on the left side, left side, you create some deficit of speech, some deficit of calculation, some deficit of various kinds of visual agnosias and things like that. Left side posterior parietal AVM is a dangerous AVM because these minor deficits, which look minor to us, are very much, they can they can just cripple the person. Speech deficit, so many things can happen in left side parietal posterior parietal AVM. Now, this is an AVM, obviously in the Broca's area, speech area, motor area, is fed by multiple small vessels, one large. So we have to understand the location, understand the symptoms, understand the patient, understand the patient. You see, you cannot say I can do and I can do. Here, one thing in AVM surgery will not help you is your ego, is your pride. If you have pride, yeah, I'm good, it will be, you will be taught a beautiful lesson during surgery. It will bleed so much that, and if you're not able to control everybody in the theater, whether it is the nurse, whether it is the anesthetist, whether it is your assistant, whether the people who are watching you will say, what nonsense is going on? So you cannot, you have to really not have any kind of ego or pride. You have to understand very carefully, study it for hours and hours, this AVM, prepare for surgery, where to go, where to enter, how to exit. There are so many issues. And most important is how to exit. Exit is all right, but whether you will be able to exit. And it should not happen that the patient exits. And any kind of deficit, many of these patients come with only very marginal symptoms like headache, symptoms like epileptic fits, symptoms like giddiness, symptoms like little bit of a vertigo, little bit of an ataxia. Headache is one very common symptom. And when the patient comes with severe headache, that is a very big indication for surgery. Of course, when it bleeds and the patient has a deficit and all those things, convulsions, very important way that these AVMs can present. This is another AVM in the region of, you have to understand where this AVM is. What are the feeders? This is a posterior choroidal velum interpositum AVM. Multiple kind of nidus, but actually this is one large nidus, one feeder major coming from front, one from behind, and ultimately they get together. Arteriovenous malformation means a collection of blood vessels. There is no brain between the AVM nidus, and you have to come and dissect. This is one huge. You see, this AVM is a little bit different, diffuse nidus, and also I can see some brain here and there, but you must understand that the basic nidus is a compact one. Then these draining veins can go outside the nidus, and this may give you a kind of a, so this AVM question is what to do and what not to do about these AVMs. So when I see an AVM picture, when I see an AVM, I think for myself, for a prolonged period of time, yes, this is easy AVM. See, there is no AVM is easy, no neurosurgery is easy. Everything is dangerous, everything is difficult, everything is having its own kind of problems. Nothing is easy in neurosurgery. But I make a kind of a guess for myself. Then second, my classification number 2 is it's a difficult AVM, but there is safe. It is in the safe area. I can handle the AVM. I can go here, and then it is not such a high flow. So this is a difficult but safe. So this is the way I classify. Very difficult and risky but possible. Not safe or not possible. So this we all know about special classification and all those things we know. But this classification is for me. And as I become more and more experienced in AVM surgery, My classification, maybe it was very difficult earlier and now it becomes difficult. It was very difficult earlier, it now becomes easy. So it is for everyone individual. Like for you, it will be this kind of classification, it is easy. So I call it a dynamic kind of a classification. Now, when we operate on the AVM, there are several issues that we have to take in our understanding. One is the site of the AVM. Second thing is number of vascular territories that are feeding the AVM. Like for instance, if an AVM is fed only by MC or only by AC or ACA and MC or ACA and PCA, and if an AVM is fed by ACA, MCA, and PCA, and all territories, so if the more the number of territories, more the high flow, more the high flow. What matters in AVM surgery is to identify the degree of flow in the AVM. How much high flow? When you see flow-related aneurysm, when you see patient coming with severe headache. When a patient comes with severe headache, it is high flow. When a patient comes with a bleed, if the patient only high flow AVMs bleed. When a patient comes with, many of these patients can come with prolonged AVM, higher function disturbances, because it is sucking the blood from normal brain, the memory disturbances, cognitive impairment, and things like that. It is a long standing, it is for 10 years, 15 years, 10 years, 15 years AVM will not be so high flow. And we have to understand the nidus very nicely. So now here is one AVM. Most important is when I see this AVM, I have to understand whether it is intraventricular, within the confines of the ventricle, or whether it is outside the confines of the ventricle. Now, if it is inside the ventricle, it is removable. But when it is outside the ventricle, it is not removable, it is not touchable. So there are various investigations that help you identify. Like we started making these kind of models with silicone. And these models gave you some kind of impression that where it is, how it is, what are the vessels feeding. And this kind of models we made for the first time in the literature. Nobody had actually discussed these models. Now you see this DTI. This is the corpus callosum. These are the projection fibers. So the whole thing is intraventricular. Now we know it is intraventricular. As we went further, this was the article that we published, 3-dimensional model printing for AVM surgery. And this is an article published some 8 or 9 years ago. So these are the models. This is the AVM. And this is the model. Now we have started color coding these models. This was a model. And when you have this model, you can keep the model in your hand during surgery. And you can get various kinds of information as to how is the feeding vessel, what is the relationship of this vessel, this vessel, this vessel, what is this vessel. So you have to sit down with this model for hours, not for 10 minutes or 5 minutes, and understand this AVM. And then only you will be able to. So this is the AVM you can keep in the hand. You can keep the model in your hand, and then you can mark the incision. Here is the AVM. Then mark the incision. I will discuss with you, but AVM surgery has to have a very big exposure. You cannot do minimal invasive or micro operation or endoscopic operation. These kind of operations are not possible in AVM surgery. AVM surgery needs prolonged operation, long operation, big operation, and wide operation. So this is the area, and this AVM was subsequently removed. This is another AVM. You see, these models can give you the external carotid supply, and this is another model showing where the vessels and things like that. Now, recently we have started color coding it. So this is the AVM. This is the anterior circulation, which is supplying the AVM, which is colored in blue. And this is the posterior circulation, which is colored in red. So you know how much part of the AVM is supplied by anterior circulation, how much supply from the posterior circulation, and then you can remove this AVM. So this is post-operative, difficult, dangerous, but you have to understand these AVMs in a very beautiful fashion. Now, this is a young little girl. You see her eyes, you see her hands, you see her hair. Quite a severe headache she is having. Now the question is, this AVM is a difficult AVM, quite a dangerous AVM. You have to sit down and think yourself whether you can remove this AVM completely and completely. You cannot remove partial and use some feeders you coagulate and things like that. You cannot do like that in AVM surgery. You do like that, you kill the person. So first thing that you have to do is sit down with the angiogram. And this is a very severe headache she is having. It is a big symptom. She is not able to live properly. And this headache, I have already told you, when you have headache, it is quite a high flow AVM. And you can see when the AVM is large in size, it is high flow. When it is multiple large vessels, high flow, multiple vein drainage, high flow, aneurysm, intranidal aneurysm, feeding vessel aneurysm, high flow. So this is a high flow, large AVM, and you have to prepare yourself. And you see, we have removed this AVM, and you see this beautiful smile. The most important thing is, if you are able to remove this, you give new life to the person. And you have to be very confident that you can remove it, because you cannot create hemiplegia in this young girl. Then you will be very heavily criticized. And of course, complications happen in our field of neurosurgery. But we have to be very reasonably sure that we enter, we exit. We cannot half enter and not exit. So this is the beautiful smile that we look for. And also another thing, patient giving consent means nothing. This is another, I did some 20 years ago, this case. Now, this patient was a young man, a farmer by occupation, and he came with this large AVM. And the only symptom that he had was severe headache like the previous girl. Now, whether for headache you want to remove this, the patient was saying, okay, you operate on me and this and that. Means consent was there from the whole family, because he was having such severe headache. But I said, no, it is dangerous, you just go. But he came back after 3-4 months and said, doctor, I am completely shattered. You just operate. I said, you can die. He said, okay, I die, but you operate. If the patient is giving consent, that does not mean you operate. If the relatives are giving consent, you have to have your own consent. You have to have your own understanding. You have to say yes yourself. And because if you are not able to remove during operation, it will be quite a dangerous situation. Now, this AVM is fed by multiple large vessels, branches from the anterior cerebral artery. In AVM surgery, interhemispheric approach is very, very important. Interhemispheric approach for pericallosal artery, interhemispheric approach for posterior PCA, I will show you. So interhemispheric, when we come interhemispheric, we have to avoid the AVM, come directly in the feeding vessel, get the vessels, and then descend. So this was we removed, and now for 20 years, this man he was a boy, now he's a man, and he has 3 children, and all 3 children are very solid farmers, and you can give a new life. The question is whether you have that courage, whether you have that potential. This is another beautiful AVM. Now you see this AVM. Also, a young boy comes with very serious headache. And also this boy had memory disturbance. He was lethargic and things like that. But that means nothing. You have to find out the weak spots of this AVM. Like in this, see here. Now here, these major feeders are from the anterior cerebral artery. Middle cerebral artery feeders are not so many. Now, anterior cerebral artery, you come here, interhemispheric, lateral, this, that, you come, and you have to plan from where to come, how to exit, how to dissect, and intraoperative parameters, various kinds of dyes are now available, as you know, and this AVM was beautifully removed, and you see the life. So what we have done is we have given him new life. In neurosurgery, that is our beautiful profession, that you can give new life to our patient. You can give completely new life. But only thing is, you cannot give him half life. Or you cannot say hemiplegia. You cannot give him complete blindness or things like that. You have to have a big degree of confidence, big degree. And it is not a pseudo confidence. It is not come with pride and arrogance. You have to have a real kind of feeling that, yes, this AVM, this is another AVM you see here. This is from in the region of anterior cerebral artery feeders, middle cerebral artery feeders, and little bit anterior in the frontal brains. Come from lateral, get these feeders from front, then get the feeders from the anterior cerebral artery in the interhemispheric fissure, then get the feeders from the NCA, and gradually go on dissecting. It will bleed from here, it will bleed from there, it will bleed from everywhere. And it can bleed from more than one spot. And this patient is a high profile person, an engineer by profession, and he has come with only symptom of epilepsy, fits. Now, whether for epilepsy you are ready to take the risk and operate, because even after you operate, epilepsy may not go. But AVM can, there are, if you leave this AVM, chances are that he may bleed to death. Chances are that convulsions may increase. Chances are that it may suck blood and he may have cognitive and memory and various kinds of disturbances. So this patient with only epilepsy, you have to find out with yourself, with your own understanding. And this is post-operative, and this guy is also completely cured from his problem, also from epileptic fits. This AVM is in the frontal brain, relatively straightforward, looks very straightforward, but during operation, this was very, very high flow AVM, tested my skills and tested the skills of my entire team. But, when you are operating, you have to be having confidence with your assistant. Or the assistant has to be understanding you, and he should be having clear understanding of the AVM. The person should have assist you in sucking the blood away from the field, sucking you in dissection, sucking the AVM for helping in dissection, and bleeding and keep the field clean, get to the feeders, and you have a beautiful clinical outcome. This AVM also I removed several, maybe 20 years ago. You see this location in the region of great vein of Galen, in the region of straight sinus, in the region of velum interpositum, in the vicinity of the brainstem. But the beauty is, come interhemispheric, have the art of, retracting the brain interhemispheric, get to the anterior cerebral artery feeder and take this feeder. And then interhemispheric, come on the PCA, come on the posterior cerebral artery, and brain has to be lax. And this PCA you can coagulate above the tentorium as the PCA comes beyond the leaf of the tentorium as it goes up, and then you identify the feeders and clip the feeder. Above the tentorial feeders, PC artery feeders are quite safe, and you have to have that artery. In AVM surgery, there is one critical thing. That critical thing is identifying normal blood vessel from abnormal blood vessel. And this will be tested throughout the operation. When it bleeds, you start coagulating here and there and take one normal vessel, you can create a big disaster. You just cannot coagulate one normal vessel, particularly in the region of brainstem, particularly in the region of any critical area. You have to have only circumferential dissection around the AVM, not within the AVM, not outside the AVM, around the AVM, continuous dissection. First get the major feeders from anterior cerebral, then get the major feeders from PCA. Here is the PCA coming, and then above the tentorium, get this feeder. Don't take the normal vessel which is not feeding, because if you take normal vessel, you may remove it like this, but you may have very, very serious deficit. So this is post-operative. This is another AVM fed by the PCA. Basically here, this is the PCA. Get interhemispheric. This is should be your friend. And this PCA, you have to understand very beautifully how to get the PCA feeders, not PCA artery. PCA feeders, how you get the feeders, spare the normal PCA. And that is very important. You cannot take any normal vessel. If you take, you see this is coming around the brainstem. Here from this point, it is going above the tentorium. Here, this vessel have to be identified and clipped. Interhemispheric, the brain has to be lax. You position it properly. You give a lumbar drainage if necessary, but brain has to be lax. And the brain is lax in AVM surgery. It is not like a glioma. It is not like a tumor where the brain is tight or meningioma, brain is tight and edema. These are chronic situations. These are benign situations. These are long-standing situations. Brain is not tight. So retraction of the brain is not difficult. Many of these AVMs look very difficult, but they may not be that difficult during surgery. Now, patient which has come with a bleeding and in a difficult situation, unconscious or whatever, you see the large intranidal aneurysms, quite a bad looking AVM coming from PCA, my friend. This PCA, you see PCA. Now come intrahemispheric anterior and get this PCA early, then get the anterior cerebral artery feeders, and then circumferentially dissect. And this patient has already bled, so it gives you a little bit. So this was the AVM, and this is the post-operative image, and this is the sample. So you have to come circumferentially beautifully. So these are very high degree of operations. Now, this is one AVM which I was talking about. You see this AVM looks, this is a very common location of AVM. And this is one location where AVM surgery is relatively straightforward. Now here there is one big PCA feeder. Then there are MCA feeders. You see this MCA feeder. Then there is anterior cerebral artery feeder. Then there is contralateral anterior cerebral artery feeder. So this is when there are multiple vessels feeding. This is a high flow AVM. And I must tell you that this AVM, in my career, this was one of the very high flow AVMs that I had operated. One difficult AVM, but this was done in a very fantastic fashion. So this was removed. Okay. This is another AVM. You see the PCA. Then there are large intranidal aneurysms. And this PCA. So get this PCA. Understanding the PCA. I will say I don't remember this AVM, but I must say this may not be such difficult. You come here, get the PCA, the entire thing will be. But you must also remember one more thing. In large AVMs, almost always, at least 90% of AVMs also have intraventricular feeders, choroidal vessel feeders, whether you see it from an angiogram or not. So this was the AVM removed. This is another AVM coming from anterior cerebral, draining here in the pericallosal area, big venous drainage, big arteries, and this was removed. This is another AVM. You see intranidal aneurysms here in a difficult area. This patient has bled and come. So what I'll do is let me show you some parts of the operation first. So you see such big exposure, okay? It may bleed from here, bleed from there. Now I am opening the Sylvian fissure. You see here, this is the anterior cerebral artery feeders. And I have to get, and this AVM, this surgery also I had done some 10 or 15 years ago. So I have not really, I don't. See here, this is the optic nerve. This is the large artery. This is the, this is one of the part of the AVM vessel, anterior cerebral artery. You see, so large it is. Then I will go on the contralateral side. This is the opposite optic nerve. Then I will get the opposite anterior cerebral artery. then I will have the whole complex of anterior communicating artery and all those things. You see, I am going on the contralateral side to get the, you see, you have to circumferentially come and surround the AVM. You have to come and engulf the AVM. Now here, if you see, this is the, from here the vessels, this is the anterior communicating artery complex. This is the anterior cerebral artery. This is the area of AVM. Identify the AVM, study the AVM, look around the AVM, get to the feeding point, get the feeder, and then identify normal from abnormal. And then, unless and until you identify the exact point of feeding artery, you cannot coagulate. And if you have any doubt, you can put a temporary clip or some kind of temporary occlusion. But here now I'm gradually, you see this, there are two things. This clip is a little larger in size. Then once I coagulate, then I cut. So coagulate, cut, and gradually dissect the AVM. You see huge vessels in this area, and all these vessels are so important. You see, this is the both optic nerve. This is the anterior cerebral artery. Just enjoy it. You must remember this, whatever this is there, maybe a little bit edited here and there, but it bleeds furiously. It bleeds from one point, it bleeds from 2 points. Sometimes it bleeds. You may get a feeling that I may not be able to handle this bleeding. So have a confidence in yourself. If you have come with confidence, you retain that confidence during operation. You have to work with confidence. You cannot lose your confidence in a situation where there is a bleeding situation. Then go on dissecting, and try to identify the plane of dissection. Work within a little bit around the AVM. Go on dissecting, and ultimately you have to, as I have told you here, maybe it has been a little bit edited here and edited there, but control of bleeding, perfect hemostasis, learning the art of hemostasis, learning the art when to coagulate, when not to coagulate, that is another thing. Second thing is where to find the feeders, where to find the draining veins, how to handle the bulk of the AVM, how to dissect, how to, another thing, which is the most beautiful, if you ask me what is the most critical point in AVM surgery, one is identifying the large vessels. Second thing is identifying the small vessels. See, small vessels lead you to the big vessel. If there is a small vessel bleeding, you coagulate, it will neither coagulate, the bleeding will continue, and these small vessels should not be actually coagulated. These small vessels lead you to a bigger vessel or mother vessel. I call it mother vessel. Go to the mother vessel and coagulate that mother vessel. And you see this here, the AVM is being gradually and aggressively dissected. Anterior cerebral artery and its perforating vessels have to be necessarily preserved. AVM has to be dissected circumferentially, but once you take the venous drainage has to be necessarily handled in the latter part of the operation. If you take the veins early in the operation, you can create some kind of a disaster, but that does not mean you lose your breath. You have to continue, you have to plan the surgery, you have to execute the surgery, and gradually and surely and definitely you have to remove the AVM, because you cannot do in this situation partial kind of resection, because you do partial resection, the person will definitely bleed and bleed to death. So this is the situation of AVM surgery, and this is the AVM which has been, nidus has been dissected. So AVM surgery is a long surgery. AVM surgery is a prolonged surgery. AVM surgery is a big surgery. AVM surgery is quite a taxing surgery for the surgeon, and the surgery taxes your skill. It challenges you. It gives you an opportunity to understand the bleeding situation, so these are various things in AVM surgery. And the question is, if you are able to remove it, you have given a new life to the person. So you take this or leave it. And if you don't give it, it has bled once, it will bleed again, and it will bleed more and more times. And then this person will not survive. So you have an opportunity that you can completely cure the person. So this is one anterior cerebral artery. This is the other side anterior cerebral artery. This is the anterior communicating artery and its branches. And you see how the AVM has been handled and removed. Okay, so this is the AVM which has been removed, and this is the AVM. This is another AVM in the Sylvian fissure. Sylvian fissure AVM is one is the AVM. See the large vessels, large draining vessels. I'll just show you a few glimpses of this AVM. You see the large vessels in Sylvian fissure. Obviously, you have to have you cannot take a normal middle cerebral artery vessel or middle cerebral artery perforator. Identifying the normal from abnormal is so much more critical in Sylvian fissure vessel. And you see how the assistant is also participating in the surgery. You have to have full confidence in your assistant, confidence in your nurse, confidence in your anesthetist. Blood has to be prepared. They have to be prepared for a long case. And the thing is, identify large vessels, identify small vessels. Small vessels cannot be coagulated. You have to take the small vessel to the origin, to the mother vessel. So we have recently published a series of cases of large AVMs that was published a few months ago. And that paper, I wish you read that paper. The title is Large AVM, Surgery on Large AVMs. My experience, I think 80 patients or something like that, which is the largest series in the world of that size of AVM. You see, it bleeds. Now it bleeds, so don't get restless and don't get havoc. It bleeds and it will bleed. And it may test, it may be an opportunity. Don't start blindly coagulating in this situation. Don't start jumping on with coagulation and all. Identify the exact point of bleeding. And then you see here that bleeding was such huge, but what was done was this cotton patty was placed and the bleeding has been captured, and it can be captured, even very heavy bleeding can be captured and has to be captured because you have entered into a situation where the bleeding and bleeding control is the answer to the question. And this AVM was ultimately resected beautifully and fantastically. And most important is you have cured the person and you have given a new life to the person. And I'm not saying that there are no complications and all those things. Don't get wrong impression. You can create complication. You can create hemiplegia. You can create disasters. But those are not, if they are quite common and frequent, then you should not do AVM surgery. This is another AVM. You see here anterior cerebral artery feeders, which is like coming entirely from anterior cerebral. Let me show you a few images of this. So what I must have done is I must have gone here, got the feeders, and unfortunately, I think we will just leave this for the time being. All large AVMs have feeders from the ventricle, and that is in the depth. And those ventricular feeders have to be coagulated, and they come at the end of the operation. Many of those intraventricular feeders are they bleed quite profusely. And having wide exposure, complete, and that bleeding from the choroidal feeders have to be very meticulously and beautifully controlled. So this is the large AVM which I have dissected ultimately after prolonged dissection. These are not quick fire like tumors. I will say most of the tumors can be removed in 1 hour or 1.5 hours. Most of the tumors in neurosurgery. If you remove a tumor in 20 hours, you don't know how to remove a tumor, except for glomus tumor, which takes time. AVM surgery takes time. AVM surgery has to be, you have to spend time and it bleeding and this and that, and ultimately you have to get vessel, avoid veins, and come here, come there, and all those things have to be understand the AVM, get to the have a good suction in your see, and also when there is a bleeding situation, my suction is in my right hand because it is more powerful hand and it helps you to control, it sucks the bleeding more powerfully. So I do right-handed suction in majority of my cases where there is a potential for large kind of bleeding. So this was ultimately resected, and this is the AVM which is resected. Now, preoperative embolization is another very big question that is asked, whether you like preoperative embolization. I work in a department, big department, where interventional radiological procedures were born in India. And very big expertise. So many of the patients come to our interventional department and I get referrals after embolization. Now, if you ask me whether you want embolization or you don't want embolization, I'm not actually very heavily convinced that embolization helps me during operation. I'm not heavily convinced, except in some locations here and there. But in general, I don't like preoperative embolization. But when this patient comes with embolization, then you have to see whether you have to operate and whether you can operate. Basically, this was operated beautifully, as you can see, and is completely and beautifully removed. This is another AVM which was one of the nightmare. You see the tubular bulb, you see the superior vena cava, huge, very, very high flow AVM, which I operated some 20 years ago. I am not sure if this comes to me now, I will have that kind of courage, because this has big potential to have complication. You see the intranidal aneurysms, you see the huge vein, and this was just, I'll show you some glimpse of this video. And this is also done several years ago. Ultimately, this was resected. You have to identify the weak spots. First get the anterior cerebral artery, then get the PCA, interhemispheric approach, and get to the AVM, and then you have removed the beautiful AVM. You see this AVM, tremendously removed, difficult operation, but you have given a new life to this lady. You see, after several years of operation, she comes. This is another tentorial AVM, which is very high flow AVM. Identify the PCA, your friend in AVM surgery. Get the PCA, get the ACA. This is my feeding by anterior cerebral artery. Get the PCA, get the ACA, get the NCA circumferentially. And remember, large AVMs will always have intraventricular choroidal feeders, and remove it. Have the confidence, have the courage, have the experience, and have the will. Don't say no in neurosurgery in general, but don't say a pseudo no. Don't say a pseudo yes. You have to be real. That is why I call it the last chapter of neurosurgery, because you know the AVM, know the tumor, you know everything. If you don't know the tumor, you can look into the tumor and say, okay, I cannot remove it. I can remove partially. Okay, it is a malignant tumor, there is no need to remove. Here, there is no this kind of confusion. Here, you have to say yes or no on the AVM. Most importantly, on your own understanding, yes, I can remove it. And you have to understand the AVM very carefully. So this is the ACA feeder. Come from here, get to the feeder. This is in quite a critical area of the brain, and this was removed quite beautifully. Now, this patient has come with hemiplegia, and this AVM has bled. I never do craniectomies in this patient, never. I don't recommend. Like, okay, I decompress now, I will come back after 6 months, or that is complete, in my view, not necessary. If you wait for 3 months or 3 or 4 weeks, this patient from hemiplegia will recover. So earlier in my experience, if I thought that I can remove this AVM, I would wait for 3-4 weeks for this patient to recover. But now, if the patient has come with hemiplegia and I think I can operate, I will not wait, because this hemiplegia gives some kind of a safety gear. If this patient continues to be hemiplegic, you are not so much blamed. However, if he has recovered and he started moving his limbs and then becomes hemiplegic after surgery, then the surgery has to be done. But this kind of AVM, now I don't wait for several weeks, maybe 2 or 3 weeks till the brain settles down, and then I will remove this AVM. And this is the post-operative. This is another motor strip kind of AVM, but there must be some good points, some bad points, some easy points, and this is post-operative. This is another AVM. You see quite a large intranidal aneurysm, venous drainage, and this was removed quite beautifully. This is another AVM. You see there is some weakness in the hand, and I'm holding this boy in my hand on the chair, of course. And this AVM is quite beautifully removed. Not beautifully removed. You're given a new life. Only thing is, you have to have that in you. This is another AVM. You see this model. You exactly know where is the AVM. In the region of the ventricle, in the region of medial, in the feeders by PCA, vein drainage by great vein of Galen. So this is the AVM, and this is post-operative. I'm just showing you many cases for you to understand what I have done, what I thought before operation it was possible for me. So you get an impression. You don't get misunderstanding and don't get into a thing, don't get any kind of feeling that, I'm showing good cases or bad cases. I am showing you cases which I have done. I am showing you cases where I had some problem also, like this patient is in a quite a area, comes with multiple convulsions, removed. This patient also, you see here, looks in the motor strip, dangerous looking, but there are some spots here. Identify, this is not nidus, this is not nidus, this is the nidus. Get to the nidus, get to the feeding vessels, and you can have to remove. This is another posterior parietal AVM, difficult AVM, young little girl, and this is the post-operative. This is the feeding vessel from anterior cerebral artery. Get to this point interhemispheric. Get to this point interhemispheric, and get to this circumferential nidus resection, and you can do a beautiful resection. So this is post-operative. You see here also, this is the post-operative. You see how it has been planned. This is the model. And I have described for the first time this contralateral interhemispheric approach to medial frontal. So come from contralateral, get to the feeding vessel. You see, if you come from ipsilateral, these veins can get damaged and this AVM can blast off. So come from, this I had described. I don't do it often, but this we have described. So this is the AVM. Now, what we can do is come from the contralateral side, get to the feeder so that the veins are not disturbing you, and then come transfalcine, then get to. So transfalcine approach was first described by me in 1995 for AVMs and for contralateral hemispheric tumors. Transfalcine approach to contralateral. Imagine 30 years ago, I described that approach. What a beautiful kind of thing 30 years ago, dangerous, but that was done. So this is the AVM you see coming from PCA, going here, going there, and this is post-operative. This is another AVM, you see how it is going in the vein of velum interpositum. You see this AVM. This is the weak point. Come from here, get this. Come from here, get the PCA, and then work around the, and this was beautifully removed, as you can see. This is another one, big AVM, large AVM from here to here, and this was removed. This patient had some speech problem, sensory speech problem, calculation disturbances, left-sided brain, left parietal signs, had little bit significant issues. So you have to understand the patient and you have to understand the needs of the patient. This was another patient operated by my associate, and you can see this tactile plate AVM, and this was recently published. And this is the AVM in the region of brainstem, get supracerebellar, get to this feeder, you can see the dissection in this article. This is another beautiful AVM, which was also done by my associate. And this was beautifully removed. Now, this patient comes with multiple epileptic fits. Now, whether you want to in this dangerous area of the brain, whether you want to operate or you don't want to operate, you want to give gamma knife, or all those things can be thought about, but this was removed beautifully. This is in the frontal brain, little bit beautiful. This is also here. And you can see some of these kind of AVMs which we have done. This is a beautiful, another AVM, large MCA feeders. You know, you cannot coagulate the whole thing here and there. You have to identify precisely the feeding vessel and then coagulate it and then dissect it, identifying normal from abnormal. So this is I cannot show you the whole thing because, you know, time is also a consideration. You cannot show anybody AVM surgery in a lecture. It has to be hands-on, kind of personalized. You have to be in the operation theater, understand the AVM, understand the dissection techniques, understand this, all those things, and so many things in neurosurgery which you have to learn and understand and perform. Most important is neurosurgery is a performing art, like dancing. You cannot learn dancing without dancing. You cannot learn dancing without practice. You have to practice. And this is another AVM, beautifully dissected. This is another AVM. You see, this is, if you ask me what surgery fascinates you now in today's world, I will say AVM surgery is one which gives me very passionate about it. I love this surgery, but love this surgery does not mean I will be having full of pride and ego and hyper confidence, but you have to be realistic. And like in this motor strip AVM, there are too many things to understand, too many things to think about. This patient I had operated several years ago in a youngish boy, maybe 20 years or less than 20. I created a big hemiplegia in this patient several years ago. That hemiplegia is almost completely resolved, but still he has hemiparesis. His gait is not normal, but he's alive and he's working and he's contributing to the society. This is another AVM. You see large anterior cerebral artery, smaller MC artery, quite a significant PCA. So you have to get, this is another beautiful AVM which has been removed, and this is the AVM. So enjoy, I hope you're enjoying seeing this AVM. Now this patient had come with a bleed and somebody had done a big craniectomy, which I never do. And the bone flap was preserved. So I operated, I replaced the bone flap and removed the AVM. So this was the AVM. I never do this kind of craniectomy and all. This is another AVM which the patient had become unconscious after embolization and things like that, you see, but because the patient was already unconscious and I was also young, energetic, waiting for such cases, I removed this AVM, but patient was not safe. This is another PCA feeder, tentorial AVM, and this was removed. Another tentorial AVM, you see this was removed. This is another tentorial kind of AVM and beautifully removed. So just enjoy this, watching these AVMs and try to understand why I took the decision to remove and what were the weak points of this AVM. This was another AVM. You see large PCA feeder above the tentorium and removed. This is another beautiful one which is removed. Another beautiful one. So this was recently published on large AVM, my experience, and you should see in that AVM my complications and all those things. Posterior fossa AVM, this patient was also a mathematics teacher and he became quite severe giddiness, and you see large aneurysms in the basilar. There were some 10 aneurysms and I removed after prolonged dissection. And this man is doing mathematics teaching now after so many years of operation. This is another very complex AVM in the posterior circulation, in the cerebellum. And these AVMs are relatively straightforward. This was another AVM in the posterior circulation. This is another beautiful AVM. This is post-operative. This AVM is the draining vein is along the trigeminal nerve. You see, this is the AVM. The draining vein is along the. This patient comes with a very high-profile person, very well-known person in India, comes with symptom of trigeminal neuralgia. I remove this AVM and trigeminal neuralgia is gone. Intraventricular AVMs are relatively straightforward, choroidal, they look little dangerous. This is in the temporal horn. This is velum interpositum. In the velum interpositum comes with a bleed, and I remove this AVM, and this is the AVM which is removed, and this is the postoperative angiogram. Intraventricular, completely within the ventricle, are relatively straightforward. Have a big exposure and have a wide exposure, and you can, attempt to remove this. This is another intraventricular AVM fed by the posterior choroidal vessels, and this is the AVM which is removed. This is in the quite a complex area AVM which was removed, not intraventricular. Now I show you another one. You see this AVM, large vessel feeder, large drainer. This is not an AVM. This is a pile AV fistula. These are different entities. One artery, huge drainage. So I didn't know about this entity till I operated on this patient. And these are relative. I just show you the bleeding in this situation. This is the large pile AV fistula. And you see here, I'm trying to dissect. Otherwise, it will not bleed. It will bleed from only one point, and that point will be quite heavy bleeding. I'm trying to dissect. Maybe I have already controlled the bleeding. Here it has started bleeding, you see, from one point. So it is arteriovenous, pile AV fistula. It is not an AVM, it is not a nidus. One large vessel, you have to come and call. We see it bleeds very furiously. And this is then removed, and this is the huge thing. There are various loculations. This is the postoperative. This is another pile AV fistula, one artery, large drainer. One artery, large drainer. You can treat by just cutting here. There is no need to dissect the whole thing. You can put emboli also here, interventional radiology. But this emboli gets sucked and goes into the venous territory. So surgery is very good. This is another pile AV fistula, large feeder, and this can be removed. This is another pile AV fistula, one feeder, and large venous drainage, and this is the pile AV fistula. This is in the posterior circulation, large pile AV fistula. You see, large, one vessel, get to this vessel and remove this. This is another pile AV fistula. This has been embolized, but this embolization can be useful in this, and this is the article I wrote several years ago on my experience with pile AV fistula. This is another in a small little child. You see one artery, and the whole circulation is going into the superior parietal sinus. You just have to do one thing here, clip this artery. And after some time, you see this venous channel have reduced, and the person has, comes with whatever symptoms get cured. So this is another pile AV fistula. Scalp AVMs are different. They are different techniques, and AVMs can grow in size. Some AVMs you have to understand cannot be removed, dangerous AVMs. So you say, no, I cannot remove it. Don't think that you have, you have failed or you are less than anybody else. If you think you cannot do it, send him out. And don't worry if somebody else attempts it and removes it. Thalamic AVM can be dangerous, may not be possible. AVM which have bled in the brainstem and involving the brainstem can be removed but can be dangerous. This is another AVM where I had said no. This is another AVM where I had said no. This is another AVM where I had said no. And there are several, this has bled in the brainstem. I had said no. Embolization has difficult, whether it has role in AVM surgery or not is a difficult question. Whether it makes a difficult AVM is a difficult question. Whether partial embolization is a good option. Whether radiosurgery is a good option. So this patient was treated by embolization by a very popular interventional radiologist. So embolized, but he developed hemiplegia following this. So we operated in the night and removed this AVM. Hemiplegia persisted, but subsequently improved. This is another AVM which was very heavily embolized on multiple stages till the time the patient bled, and then I removed it, but this patient never recovered. So thank you, my dear friends. I hope you have seen some beautiful AVMs, and I hope you have enjoyed this journey of mine and this passionate experience of mine. I love AVM surgery. Loving AVM surgery does not mean I'm the king of AVM. It is the absolute last chapter of our subject of neurosurgery. You must remember we can cure these patients. We can give new life to our patient, but it depends on us, on our experience and our talent, our competence, our technique, our technology, our theater, our assistant, our nurses, our anesthetists. The whole circumstance when you are operating, you have to be comfortably poised, no disturbance, beautifully like meditation. This is another kind of a meditation. So thank you, Noor. Thank you, Yandong. And I hope I have several questions.
Thank you very much, sir, for this very amazing and insightful talk. And there are so many compliments for you in the chat box. I can see that everyone is really impressed and really found it very insightful and interesting. So thank you very much, sir. It was like going on a virtual tour to your clinics to see all those amazing patient cases and all those decisions. And I think this is going to be really impressive because I believe that showing the examples and the cases is basically what means so much to everyone because it helps us so much in relating to the real life cases when we come across those. So I believe that there will be questions as well, sir. There is also one question in my mind, sir, that they say that the AVMs they can cause hyperperfusion, chronic hyperperfusion, and the vascular steel phenomenon, etc. That actually leads to some cortical plasticity, and sometimes the eloquence is the centers are being shifted. That basically leads to downgradation of the AVM because obviously we are much concerned about the area being eloquent. So sir, do you believe they said that you can do this fMRI and things like this and just say that it's no longer that much of a concern for you if the area has been shifted? So do you believe that this is true, and have you ever practiced it in your own experience?
So this is a very interesting, very important question. This is a normal perfusion pressure breakthrough concept. Now, this was introduced by Robert Spessler several years ago, where he said that if you attack a large AVM, the normal vessel around the AVM can bloat up and there can be a perfusion breakthrough. And you can damage. But my feeling is absolute. As you have seen, my experience in large AVM is the largest in the world. I have not seen any report. Maybe somebody has, I don't know. But I think that at least there is no report in the literature. Now, my feeling is if you remove the AVM completely, you will not get normal perfusion pressure breakthrough. The problem is these small vessels. These small vessels, you spend a lot of time in coagulating. You cannot just coagulate. So what is the trick is, understand these small vessels. You have to follow these small vessels to the mother vessel. Get the mother vessel. If you get the mother vessel, the AVM is completely removed. You coagulate small vessel and you get some kind of hemostasis and you come out, this mother vessel will bloat up immediately after surgery. My feeling is this normal perfusion pressure breakthrough concept is like a, it's like a safety parameter for us. Like if we have not done a good job and if it bleeds, you blame it on the normal perfusion pressure. That is what we do normally. That if it is, if the tumor has bled, we say the tumor, something is wrong in the tumor. We are not wrong. Like something is wrong in the AVM, this normal perfusion pressure has broken the artery and all those things. So we are not wrong. We have done beautiful job. Our hemostasis was perfect. So it is a kind of a safety parameter for us, more than a real parameter. If you have removed it completely beautifully, you should not get uh, normal perfusion. And this question has been asked to me by several people on several occasions. Even I, once in the meeting, Professor Sami was there. And Sami also said that he also does not believe in this normal perfusion pressure breakthrough. And he said that if you remove the AVM, you don't have this problem. So that is the thing. No.
Thank you very much, sir. Sir, I also actually basically wanted to add that add the fact that many times they say that if there is a long-standing AVM over there, it leads to some chronic hyperperfusion that actually causes shifting of the eloquent centers from that particular area, which sometimes is a concern when we are operating on the patient, because it's a part of the specular margin grading as well to have this eloquent area, and that means that you are not it's not going to be like so much amenable to the resection, because you are going to affect that area. So it's like a natural phenomenon that there is neuroplasticity, and that area has been shifted because of vascular steel and chronic hyperperfusion. And it's just like stroke, and like in stroke it leads to the cortical center, not the subcortical ones, because subcortical fibers that do not show that much of plasticity. So, sir, do you believe that it's a phenomenon that sometimes some AVM that you was considered to be non-operable because of several different reasons, obviously? Do you believe that sometimes with chronicity you might have the option of finding it operable later in life, or you have changed your mind because of some reasons? So, if there is anything like that, we will be so interested to know.
See, AVMs, there are, as you have seen, that there are several AVMs where I said no operation. Okay, I said
Yes.
don't operate. So you wait. And many of these patients just go on for a long period of time without any problem. But in my own series, there are several patients who were then admitted in emergency with a bleed and in an unconscious state and in a desperate state. And then you operate and then you have a very difficult situation. So bleeding in large AVMs in particular, there can be quite a significant number of these patients that can bleed. And as when they come with the bleed, then they can be in a desperate situation and they can means it is difficult to save them. Then they are dead almost. The other thing is AVM surgery is very, very important to understand normal vessel, identify normal, save normal. Don't have to, if you take one normal vessel anywhere in the brain, you can have a very difficult situation. Here I can see one more question from Dr. Harshad Parikh, my dear friend. Harshad, are you on the screen? Or you can ask on the screen if you are.
I see if Dr. Harshad, can you unmute yourself?
Atul,
Yes, yes, Harshad, yes.
how are you?
I'm very good. I
I
hope.
enjoyed your this talk of AVM. Wonderfully presented. As always, you do that. And you are a great believer in excision of the AVM rather than going for embolization or anything else. And you don't believe in the endovascular. Just a small question. I'm not asking it. Suppose a patient comes to you with a headache or epilepsy without any deficit, without any bleed, what will you recommend to us?
See, many of the AVM patients come with only symptom of headache. Many patients come with only symptom of epilepsy. Many patients come with only symptom of giddiness. Many patients come with only symptom of higher functional disturbance. but they are otherwise intact. They are walking around, they are normal. So you have to, in that situation, you have to be very, very meticulously understand the AVM. If you think you can remove the AVM, it is the best option because you cure them. But whether you can remove or not remove, this will depend on your own understanding of the AVM, own experience of AVM. So that is the most critical question in AVM surgery, to understand your own skills, understand your own talent, understand with your own experience whether you can remove it. Because if you remove, the headache will be gone. When you remove, the epilepsy will be certainly reduced, if not cured. If you remove, the vertigo will improve. If you remove, you will cure the person from any danger of bleeding. So if you remove it, it gives a new life to the person. So I will remove it if I can remove it. But if I think that there is a lot of danger in removing, big problem can happen. So I will not remove. So this is a very big decision-making process in AVM surgery.
So do you also believe in the recurrence of AVMs? Because there are several different reasons which has been described, including some residual that was being left and the surgeon was not able to detect it. There was some thrombosis that was later recurrent, something like this, and vascular phenomenon. But sometimes they say that in pediatric cases, there is a chance that it might recur. So do you have you ever seen it yourself? And if you have seen, how did you manage that patient?
I have reported one patient. I have reported progression of residual AVM. So if you leave the residue, there can be a progression, which is an absolutely rare phenomenon. It does not happen always, but it has happened even with me to the extent that I have reported it. But in general, it does not happen. If progression is AVM is a congenital issue. AVM is not a progressive phenomenon. It is not a progression. It is not a cancer or tumor which increases in size over the period. It is a malformation which happens since the birth. It is not a
Exactly.
tumor. So you have to understand the AVM, understand the mechanics of AVM, and then you have to do a beautiful operation.
Exactly, sir. Very nicely mentioned. So there is another uh, question for you. Any advice? Dr. Mohammed Al Mazolgi has sent this question for you. Any advice for practice operating AVM and advice for identifying the normal perforators and vessels and the abnormal ones? And any advice, tricks, or methods to use to help understanding the nidus and to prepare for the surgery?
There is
He
no trick. There is no
yes,
trick, my dear Mohammed. There is only hard work. There is only, you have to be enjoying the smell of the operation theater. You have to be inside the operation theater. You have to be operating on gliomas. You have to be operating on meningiomas. You have to operate on spine. You have to operate on various parts. Continuously operate, learn the art of hemostasis, learn where to coagulate, learn how to get hemostasis in the most dangerous areas of the brain and the spine. Learn how to handle arteries, learn how to handle venous bleeding, learn how to handle small bleeding, learn how to handle more than one spot of bleeding at one time, which happens in AVM surgery. It may bleed from here and there. And most important is try to have your own confidence in controlling of bleeding. Even craniovertebral junction surgeries can be very highly bleed. The bleeding can be quite high in craniovertebral junction. In cavernous sinus surgery is all bleeding. In petroclival meningiomas, so the beauty for me is I have been involved all my life in a bleeding situation. Blood has been a part of my life, and bleeding control has been my profession. And that has given me a big advantage because more and more operation all the time in operation theater for so many years of my life. It has given me that advantage. Mohammed, you understand what I'm saying? Maybe Mohammed wants to comment. Make him unmute and let him talk.
I ask him. Dr. Mohammed, would you please unmute yourself. I'm allowing you to ask the question directly.
Of course, of course. I have tried. Can you hear me now?
Yes,
Yes?
yes.
Yes, you can turn your
Yes,
video
thank
on
you
as
very
well.
much. Yeah, okay. For sure, I hope so. So I can see Sarah and he can see me.
So you enjoyed the AVMs,
Well,
Mohammed?
yes, yes, of course, of course. It's very interesting talk. And I always remember you when you say the blood is the difference between the life, the dead person and the life. So, and the AVM surgery is the surgery that's really makes you feel that the blood is running inside the live person, and you go through the blood the whole surgery from the beginning, from skin to skin actually. I know you are a master, and I know it's the surgery that you always like. I just want to ask you, maybe you use some model, you use something to prepare for surgery, but it helps the young people actually more than you. And I wish I come to India and see you operate your surgery of, of passion and love. Also, I want to ask you, when you follow the small perforator to the mother vessel, to the big vessel, like do you go to the adjacent sulcus or you just follow the small perforator?
You have to
Do you
follow the
just go
small.
directly to the sulcus or not? Or you follow it?
You follow the vessel, and if you have to sacrifice the brain around that vessel, you have to sacrifice the brain. Sometimes it is embedded in the brain, and you have to little bit sacrifice the adjoining brain of small vessel and then rapidly go. At that time, you cannot have a bleeding and you start dissecting elsewhere. You go through the brain. And majority of times you can easily go through and sacrifice little bit of brain and go to the mother vessel. Essential it is
Uh,
reach the mother vessel. It is important.
Yes, 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 I know. I do agree, actually. I've seen a lot of this surgery, and I do agree. You never finish the FAM until you finish the mother, actually. That's
That's
why you have to go to the mother first.
yes. Yang Dong, what are you saying, thinking?
Yeah, now I'm in my first chapter, and I have finished 3 cases of aneurysm clipping last month, but I think now AVM is so formidable for me. According to your classification, I think every AVM is very difficult and risky for me. But I think without any question in the future, when I get to my last chapter of neurosurgery, my AVM patient will be blessed by your concepts. And I think I will. So very, very, very amazing, very, very amazing lecture, and very, very amazing cases. Thank you so much.
Thank you, Yang Dong. Thank you. Noor, any other question for me?
Thank you very much, sir. I don't think there are more questions in the chat box. And, there is one. Okay, sir. Ibrahim Shahod, how to differentiate between a high and a low flow AVM?
Yes, this is a very important question, and it is the most important question. And there are various parameters. You know what? One thing is there, if you are operating on AVM, you must go to the DSA room where DSA is being done. So you see how you can see the flow when they are putting the dye, you see the flow of the AVM. I will say you must always go to the DSA room and see the AVM flow. And that gives you a lot of impression. You see, if you ask me, intranidal aneurysms, feeding vessel aneurysm, AVMs with present with bleeding, AVMs with present with very severe headache, AVM presenting with multiple feeding vessels, AVM having multiple large veins and multiple large arteries. So these are some of the parameters that says that this is a high flow AVM. And location is one thing which can be dangerous, but flow is the most important issue during how the degree of flow. Because if it is a relatively small flow, slow flow, then the surgery becomes easier. But if it is high flow, the surgery can become quite dangerous during operation. But dangerous means you have to be prepared for all kinds of dangers. Because if in the operation you get into dangerous situation and you're not able to handle that situation, you kill the person. So it is very means it is a quite a situation. So you have to be strong, you have to be smart, you have to be absolute.
You have to go to India.
Yeah, yeah. So thank you, Noor.
Thank you very much, sir. I think that it is us who is really thankful to you for your time and for sharing your knowledge. So basically, we owe you a huge thanks, all of us. And it's I like I always say, it's so surreal to have you here with us and to learn from you directly. So much grateful to you, sir. Thanks so much. And today's session was really incredible, and I think everyone really enjoyed it.
Thank you, Noor. Best wishes to all of you. Enjoy this
Thank
beautiful
you, sir.
subject.
Thank you.
Enjoy this beautiful subject of neurosurgery. Okay, enjoy.
Thank,
Okay, thank you. You have
thank you
you
very
have
much,
made it
sir.
enjoyable for us.
Thank you, Mama. Thank
Thank
you.
you.
Thank you, Young
Thank
Dong.
Bye bye.
Thank you, Noor. Thank you, everybody.
you.
Bye-bye.
Bye bye. Thank you very much. Thank you everyone for coming today as well. And I think that you have all seen the link to the certificate that I have shared in the chat box. Plus, today we do not have a quiz because I've been traveling myself. So I just arrived in Lahore and I'm traveling again. I'm going to catch my flight to New York in a couple of days. So I'm sorry I didn't make the quiz, but we still have the same method to change your certificate. So kindly click on the link and enter your name, and the certificate will be emailed directly to you in your inbox. So again, thank you very much, sir. It was a pleasure to welcome you. It was a pleasure to listen to you. And everyone, thank you so much, sir. And have a wonderful rest of the day, sir.
Thank you. Bye-bye.